Professor Contreras, I'm going to ask you next about the practice of transfusion and the use of transfusions and steps taken by the centre in that regard. Can we start by looking at a document we've already looked at, but a different page, HCDO 40861. So we're back in the 1973 notes on transfusion, and if we go to page 4 for a useful summary, second and third paragraphs in bold print, a transfusion should never be given without a definite indication. Not only is this in the patient's interest, since an element of risk is associated with every transfusion, but supplies of blood are not unlimited, and with the ever-growing demand for blood, it is imperative that it should not be used unnecessarily. The use of transfusion to correct moderate or slight degrees of anemia that could be overcome as effectively, if more slowly, by other means, seems unjustifiable unless some cogent reason for speed of recovery exists. In some instances, failure to institute simpler and safer but equally effective treatment earlier leads to the quite unnecessary use of blood transfusion. First of all, Professor, do you agree with what's set out there?
Totally.
And would you agree that what's set out there was nothing new, even in 1973?
I think so.
If we then move forward in time to an article you wrote in 1989, NHBT 005790, please. So this is a publication, 1989, New Trends in Blood Transfusion, authored by you. And if we go, please, in the first page to the left-hand column, second paragraph, you say, blood transfusion in clinical medicine has experienced significant changes in recent years and rapid developments continue to take place on many fronts. Numerous factors will determine the future use of blood and blood derivatives such as, and then this was your first paragraph, the tendency towards a more rational use of blood and blood components for those patients who really need them. Education of clinicians on the proper use of blood is now becoming an accepted aspect of medical training. Responsible clinicians are re-examining the benefit to risk relationship of blood transfusion. However, there is a great deal of ground to be covered, since many clinicians consider blood and blood components on the same level as any drug that they prescribe. In some countries, the establishment of hospital transfusion committees has helped a great deal towards a more rational use of blood, and it is expected that such committees will be established in more and more hospitals worldwide. And then you set out a number of other factors I'm not proposing to go to, but it's this issue about a more rational use of blood and blood components that I want to explore with you. Looking at really the period from 1980 onwards when you became Deputy Director, in your experience, to what extent was the kind of guidance we saw in notes on transfusion cautioning against overuse of transfusion? To what extent was that faithfully adhered to by clinicians in your experience?
No. No, not until later.
And so is it right to understand that both unnecessary transfusion and over-transfusion were problems?
Yes.
And that's why, as I understand your statement, you regarded it as an important part of the centre's responsibility to try and advise and educate treating clinicians on the principles and ethics of blood transfusion.
Yes.
Do you have a sense of the extent to which that was done by other regional transfusion centres outside of the North London Centre?
Not really.
Now, if we go back to your witness statement, page 92, you've set out from paragraph 367 onwards a number of measures which were taken by the centre. So 367, an important initiative that the consultants and I were very committed to was liaison with the clinicians in the hospitals we served. We introduced the concept of joint transfusion medicine consultant appointments. What was that?
Region funded my centre for additional consultants, and So we offered joint appointments to some of our main user hospitals, some of the large teaching hospitals. And we initiated we started that initiative that was that we funded half of a consultant, or sometimes a full consultant, but to be half of the time at the transfusion center and half of the time running a blood transfusion department in a hospital, the blood bank and all aspects of transfusion in that hospital. And that worked very well, and it's continued. And that gave rise, I think, to with other initiatives from our center, to the Better Blood Transfusion Initiative.
And we'll come on to that. And then the paragraph 367 continues, we educated clinicians in the appropriate use of blood, meaning that blood components should only be used when strictly necessary and in the absence of alternatives. Then paragraph 368, we started hospital transfusion committees for education in transfusion medicine and to monitor blood component usage. We performed audits of the usage of red cells, FFP and platelets, and showed that there was a great deal of unnecessary transfusions. Bottom of the page, we wrote a number of publications and gave numerous lectures regarding the risks of blood transfusion and measures to increase its safety. Go over the page. We organised meetings on transfusion-transmitted infections to educate and update the medical community. And then paragraph 373, in essence, we were the precursors of the Better Blood Transfusion Initiative of the UK Chief Medical Officers, which eventually managed to significantly reduce the usage of red cells and FFP in the country. The less blood components are used unnecessarily, the less possibility of transfusion-transmitted infections. Now, I'm going to ask you in a moment about some of the individual initiatives, but first of all, can you assist us with understanding what the Better Blood Transfusion Initiative of the Chief Medical Officers was and when roughly that took place?
It was an initiative that came from the blood services to the Chief Medical Officers in the UK medical offices. So it came from also with the help of our Scottish colleagues, who were also very interested in appropriate use of blood, or that's now called patient blood management. And we went to the Department of Health and to the Chief Medical Officer and convinced him with raw data of our audits that we had done in blood transfusion, that now other consultants in other centers were doing, that there was inappropriate use of blood, of fresh frozen plasma, of red cells, of platelets, and that there was a great variation. For the same hip replacement, you would have a hospital that on average use 0 or 1 unit, and another hospital would use 5 or 6 units. And we showed this data to the clinicians, and we showed this data to the Chief Medical Officer. And this happened with fresh frozen plasma, with red cells, with platelets, etc. And so the Chief Medical Officer was convinced that something needed to be done, and wrote circulars, aided by the transfusion service consultants, on the appropriate use of blood. And I think that was the origin of the pre-admission clinics that many of you might have seen in hospitals, where before you have elective surgery, you go a month before that to have your hemoglobin done and your all tests, so that everything is corrected before you go to surgery, and not go to surgery with anemia, for example. So that was the Better Blood Transfusion. And I think there were 3 circulars, and it's now called patient blood management. And they also recommended that there should be specialists in transfusion that were not only consultants in charge of blood transfusion, but there were also nurses or medical laboratory scientific officers that were checking that blood was used appropriately, and we're educating junior doctors on the appropriate use of blood.
And do you recall when that initiative was? If you don't worry, because we can find out easily by other means.
I can't remember when the first one was.
Then, dealing with a number of the initiatives you describe in your statement, in terms of the training and education of clinicians, did that involve your colleagues going into hospitals in your area and lecturing or holding workshops or seminars? Yes,
we were very, very involved, you know, since I started in this country, more or less. But we were involved in going to hospitals and asking to, more or less, to be invited, and going to grand rounds and going to hospitals and educating the consultant hematologists and MLSOs, inviting clinicians to our center. We had regular meetings, annual meetings with consultants and MLSOs in charge of the blood banks to educate them about transfusion. And we also taught at all the medical schools that were in our catchment area, and we lectured nationally and internationally. And with the hospitals that you were going into, was your audience predominantly haematologists and the MLSOs, or would you seek to deliver training or educational information, say, to gynecologists and obstetricians or to surgeons? Would it be across a range of different disciplines? Yes. Well, we more or less asked to be invited to meetings of the College of Surgeons, College of Anesthetists, so that we would, and we involved them in transfusion medicine. We also educated at the hospital transfusion committee level, where there were representatives of surgeons, and we also educated them through audit, because we showed them the results of the audits, and that we had meetings with surgeons or anesthetists. Yes, you've said in your statement you performed audits of usage of red cells, FFP platelets, which showed a great deal of unnecessary transfusion. So you would follow that up, would you, with the hospital or centre that was audited? Yeah, we went to the hospitals and said, here you are. You know, why are you using so much? What's the justification for you using 5 units for this type of surgery when the mean is so much and these hospitals are using so little? So some clinicians did not know how much blood they were using. Do you recall if the training and education that the centre provided covered issues about patient consent to transfusion and the kind of information about risks that should be given to patients? Yes, we tried. Yeah, we tried to get involved in the consent form for hospitals, and I think we managed it through the Better Blood Transfusion Initiative to include transfusion as a risk in the patient consent form. Do you have any sense of, it's maybe an impossible question, but it's a question I've particularly been asked by core participants to ask. Do you have any sense of what difference it might have made to overall infection levels if doctors had been educated on patient blood management at a much earlier stage? I think it would certainly have made a difference, because, you know, sometimes top-up transfusions, for example, were not necessary, and well, and as our audit showed, yeah, it would have made a difference because much less blood was needed in the country. The less blood you give, the less infections you transmit. Can I ask you to look at one letter you wrote to the Department of Health in 1990, NHBT 40/189_142, please.
This is a letter you wrote 31st of May 1990 to Dr. Hilary Pickles. She was a principal medical officer in the Department of Health. And in the second line, you say, I'm writing to give you some information on what we've been doing at the North London Blood Transfusion Centre to improve knowledge of blood transfusion and promote sensible usage of blood and blood derivatives. And then if we go towards the bottom of the page, you're dealing with a number of aspects of the proposals for cross-charging, which I'm not going to spend time on. The last two lines of the page, an audit recently conducted by us in 5 major hospitals revealed no justification for the use of more than 50% of fresh frozen plasma. And then if we go to the third paragraph on that page, the consultants at this centre firmly believe that it is only through continuous contact with and education of our user hospitals that we will be able to improve the practice of clinical blood transfusion and make the best use of blood derivatives. NLBTC supplies over 50 hospitals in the NHS, SHAs and in the private sector. These hospitals have each been allocated one consultant who pays regular visits and is available for help and advice. Just pausing there, that's a practice of the allocation of a consultant. Do you know when that started?
As soon as I was appointed, more or less, director, and I asked for more consultants, and we distributed the hospital.
And then it continues, during visits we discuss transfusion practices within the hospital and give clinical and technical advice when required. We monitor blood transfusion laboratory stocks and returns on a monthly basis and discuss the introduction of new forms of therapy which might increase demands on the transfusion service. We encourage blood donation in hospitals by staff and patients' relatives and are now starting to see much greater cooperation from hospital authorities. And then if we go to the last paragraph on this page, we believe that the way forward in clinical blood transfusion is the establishment of hospital transfusion committees with representatives from those clinical specialities most concerned with blood usage, including a nursing representative. Such committees should meet on a quarterly basis and should deal with matters such as transfusion practice within the hospital, use and abuse of blood and blood components, audit of the use of blood, etc. As a first step, we recently conducted a retrospective audit in 5 major hospitals supplied by NLBTC, looking at the practice of transfusion of platelets and fresh frozen plasma. It was necessary to search for a total of 600 case notes in order to provide 200 cases for this audit. Review concluded an assessment as to whether the transfusions were indicated. Results of this analysis were disappointing, particularly for FFP, where only 21% of transfusions were indicated and 60% were definitely not indicated. With respect to platelets, only 53% of transfusions were indicated, while 19% were definitely not indicated. From this retrospective audit, we concluded that improvement in all aspects of transfusion practice is necessary. Education regarding the value of blood, top of the next page, components and areas in which their use cannot be justified is particularly needed. Hospital transfusion committees are now being established in the 5 audited hospitals, and we intend to encourage a further 5 hospitals to move in this direction in the very near future. We view the audits as a means of education and not as a reason for reprimanding users. I want to ask you 2 matters arising out of this letter, Professor. The first is, can you recall what, if any, the response of the Department of Health was at that time to the kind of issues you were raising here?
Well, the ultimate responsibility laid with them, but this was our local initiative. So, you know, I felt it was my duty to inform them of what we were doing. And, you know, eventually it led to the CMO being interested in this aspect.
Well, no doubt we can ask the Department of Health about that. And then the second matter I wanted to ask you about is about the hospital transfusion committees. So you describe here them being established in the 5 hospitals that you'd audited. Was that the first establishment of hospital transfusion committees in your area that you're aware of?
Yes, in my area, yes.
Do you have any sense of how quick other regions were to pick up upon the establishment of hospital transfusion committees?
I think that some were quicker than others, but that's all I can say.
And what essentially was the purpose and remit of the Hospital Transfusion Committee in a nutshell?
It was to make clinicians aware of the usage of blood and of the risks of transfusion and of their own practice of transfusion. Make clinicians aware of transfusion medicine, because it was a non-entity before. They took it like saline, you know. So it was mostly educational and to share information at hospital level on transfusion medicine.
And would someone from your centre sit on the hospital transfusion committees established in your region?
Yes, always a consultant, you know, including me.
I'm going to move then from transfusion practice to a new subject now, the last, I think, topic for the afternoon. And that's specifically in relation to AIDS and the response of the Blood Transfusion Service, and in particular the response of the North London Regional Transfusion Centre. First of all, in terms of your own knowledge about AIDS, you've told us in your statement that one of the publications to which the centre subscribed was the MMWR. And you would read that, it would come to you, you'd read it, and then you'd share it with colleagues at the centre. And so, as I understand your statement, you were aware of the reports that emerged 1981, 1982 about this condition, and you were aware of the first reports in, I think, July 1982 in the MMWRs in relation to patients with haemophilia, and then aware in December 1982 about the San Francisco baby. Is that
Yes.
right? And if we just go back to your statement, Shamik, if we can have that up on screen again, page 63. Paragraph 251, you say this: I believe a pivotal moment in my view shifting. Sorry, I should read the previous paragraph to make sense of that. So you say in paragraph 250, at first I did not link this disease, which was reported to be confined to homosexual men with blood transfusion. And then 251, I believe a pivotal moment in my view shifting was when I read a report by the CDC and the MMWR of the possible transmission of AIDS to a multi-transfused infant in San Francisco. The donor of the platelets transfused to the infant was a homosexual male subsequently found to have AIDS. I believe that this report was published at the end of 1982, and your recollection in terms of the date there is correct. So, can you recall what discussions were held either within the centre or with other colleagues following the report of what had happened to the multi-transfused child in California?
No, I cannot.
So you recollect it was a pivotal moment in terms of your own knowledge, but you don't know the extent to which the view was shared by colleagues.
I must have shared it with Dr. Barbara and Dr. Hewitt, but I can't remember what we discussed. Yes.
Would you agree that that report should have been a trigger for the National Blood Transfusion Service generally to consider what action, or to consider whether action was required, and if so, what action, and to do so urgently?
Yes.
Now, I'm just going to ask you to look at some documents from 1983, conscious as I do so that you were at that stage the Deputy Director and not the Regional Transfusion Director, so you weren't attending RTD meetings in the course of 1983. But if we start with NHBT 009285_008, please. This is a meeting 12th of May 1983 of the Eastern Division Consultants in the Blood Transfusion Service, and we can see that Dr. Davis was present, but you also were present. And am I right in understanding the divisional meetings weren't limited to the regional transfusion directors? Other consultants at the centres would attend these meetings?
Yeah.
Now, if we just look down the page, over the page, I'm trying to prove a negative here, and to the next page, there's nothing I can see in this document which suggests any discussion about AIDS. Does that surprise you that at May 1983 the Eastern Division's not got it high up on the agenda?
Now it surprises me. At the time, I don't think it did.
And then, still in May 1983, if we go to NHBT 0109173, please. If we just look at the bottom of the page, this is dated 23rd of May 1973. I've read that as just a typo, and it should be 1983. It's dealing with AIDS, so it clearly can't be 73. And I've assumed the rest of the data is probably correct. It's from Dr. Davis, your predecessor as director. And if we go to the top of the page, we can see this is directed to all medical officers, receptionists, and then to you and to Dr. Brozovic for information. And then we can read what Dr. Davis was saying. This subject, so headed AIDS, this subject has attracted considerable publicity, and in view of the not yet proven possibility of transmission by blood and blood products, the transfusion service is involved. At the recent transfusion directors meeting, that's the regional transfusion directors meeting in May, it was agreed that donors should not be questioned about their private lives, and until more information is known about AIDS, reasonable attempts should be made to advise homosexuals to refrain from giving blood. It is hoped that a pamphlet giving this advice will soon be available for distribution at donor clinics. In the meantime, there must be no questioning of donors about their private lives. And should a donor volunteer the information that he is homosexual, gay, tell him that current advice is that he should postpone giving blood until more information becomes available or a screening test for AIDS is developed. If he insists on giving, accept without argument and bleed into a single pack. There is no need to make a note on the 101 or the pack. Some reports suggest that the risk of AIDS increases with the level of promiscuity and more so if associated with drug abuse. If a donor volunteers the information that he's in this category and insists that he wishes to give blood, inform him that until the AIDS risk has been clarified, his blood will be used for research or laboratory purposes only and not for transfusion. If he agrees to this condition, bleed on the B sheet, use a single pack, and label for Dr. Barbara AIDS and enter hold on the B bleed sheet. Now, I want to ask you about a number of aspects of this. If we go back to the first paragraph, if we just look at the whole, that's perfect, Shamik, thank you. It appears to have been Dr. Davis's firm view that there should be no questioning of donors about their private lives, which the inference, I think might be drawn from this, that there would be no question to the donor, are you gay, are you homosexual? Was that your understanding of what was being suggested?
Yes.
And did you agree with that, as far as you can recall?
Not really, because we thought that there was nothing. I started thinking that there was nothing wrong in asking, thinking about the patient, that there was nothing wrong in asking donors about the sexual practices.
And then can you, in any event, help us understand what Dr. Davis was proposing in the event of a donor volunteering that they were gay? The suggestion is, the advice is postpone giving blood. That's perfectly understandable. But then it says, if he insists on giving, except without argument and bleed into a single pack, there's no need to make a note on the 101 or the pack. Does that mean that the blood would be used?
No. It would go to the microbiology laboratory, to Dr. Barbara, and where it would. I can't remember what it would be done. What would be done, but we would not use that blood for transfusion.
Is that right, Professor Contreras? Because we can see that's clear in the last paragraph, where Dr. Davis appears to be dealing with the category of donor who volunteers that they are promiscuous and or use drugs. And there's a clear steer, the blood will be used for research or laboratory purposes only, not for transfusion. And there's a description that will go on the label for Dr. Barbara AIDS with word hold. So Dr. Barbara would, in those circumstances, presumably know that this was blood that was not to be used for transfusion. But in relation to the category of donor described in the second paragraph, who simply volunteers that they're gay, but insists on giving, Dr. Davis is saying there's no need to make a note on the 101, so that's the donor form, donor card, or the pack. So Dr. Barbara or the other microbiologists would have no way of knowing, would they, that that was a unit of blood from a donor who had volunteered that they were gay?
But then he says, if he agrees to this condition, bleed on the B sheet. And the B sheet was not for transfusion, not for... So I assume that it meant that with the mechanism there being bled on the B sheet, it meant that it was not for transfusion.
Okay. I'd read that as limited only to the category of donor who's promiscuous or drug use, but perhaps we can ask Dr. Barbara what his recollection is.
Well, I think that my own interpretation of this would be, if one looks at the last two paragraphs, the second paragraph, one beginning in the meantime, that looks as though it's dealing with somebody who is gay, but is not, doesn't say I'm promiscuous, and doesn't say I've been taking drugs by injection. Then the next paragraph, by contrast, deals with someone who may say they're gay, but certainly says I'm promiscuous, and in particular if the promiscuity is in any way associated with drug abuse. So that's a different category. So, and it says if the donor volunteers the information is in this category and insists, so you've got second paragraph, somebody who's not admitting to promiscuity or drug use, insists on giving. Last paragraph, someone who does say I'm promiscuous or I have abused drugs or both, and insists. And then the difference is, in the second paragraph, except you bleed into a single pack and don't make a note. Last paragraph, you do bleed into a pack, but you do make a note. That's how I read it. So I was reading as counsel has read it. And it may be, it's not your document, so it may be you haven't had a chance to look at it and think about it. But do you see the point that I'm making?
Yes, and I think it's very confusing.
Yes. Yeah. It's not clear, is it?
No.
So that's May 1983. You tell us in your witness statement, your recollection is that the centre started a draft of its own leaflet through Dr. Davis and Dr. Barbara, and then eventually the national leaflet was produced. Just in terms of the timings, I'm not going to take you to all the documents because we know the time, that we know the dates. Dr. Wagstaff circulated what was intended to be a final version of the leaflet to regional transfusion directors on the 6th of July. For the benefit of the transcript, but we don't need to go to it, that's NHBT 0020668. And then The first national leaflet was issued at the beginning of September. That's BPLL 0007247. And I will ask you to look at that. Sorry, BPLL 0007247, thank you. So this is the September 1983 leaflet. Will donors be questioned on sexual matters when they attend to give blood? Definitely not. If we go to the next page, we've got the risk categories identified. Who is at risk from AIDS? Certain groups of people appear to be particularly susceptible. These are homosexual men who have many different partners, drug addicts, male and female using injections, sexual contacts of people suffering from AIDS. And then the question, can AIDS be transmitted by transfusion of blood and blood products? Almost certainly yes, but there's only the most remote chance of this happening with ordinary blood transfusions given in hospital. We know that the leaflet then was changed with later versions, so that the reference to homosexual men who have many different partners became a reference to practicing homosexuals or bisexuals, and then in due course, just a homosexual. Do you have any thoughts on whether that took too long to make those changes, and whether this first leaflet could or should have been in clearer and starker terms?
My personal view is that it could have been clearer, and with talking to the male gay community, they didn't mind being asked these questions. But you have to remember that at that time, people didn't talk about their sexual activities or their sexual preferences. So it was very difficult for some of my older colleagues to think that you could be open with donors and ask them questions. So I think it took too long.
Now, we can take that down, thank you, Shamik. In terms of the method of distribution of the leaflet, we know from a meeting of regional transfusion directors in September 1983, I don't think we've given you those minutes, Professor, because it wasn't a meeting you were at, that centres were encouraged to use different methods of distribution, and there were three main methods identified: sending the leaflet out with the call-up to donors so that they could read it in the privacy of their own home and decide not to attend, handing it to the donor on an individual basis at sessions, or leaving it available in the session for donors to pick up. I want just to ask you to look at a document which indicates what the practice was at Edgware at the North London Centre. So it's CBLA 0001820. This is a document for the Advisory Committee on the National Blood Transfusion Service, AIDS leaflet, first 6 months experience. And then if we look down the list, we can see Edgware, available at sessions, number used 4,000, stock 46,000. The effect on donor response or attendance is described as nil. And then the comment is, donors say helpful and informative. High-risk donors have asked, will they ever be allowed to give blood again? So it would appear that the method chosen for distribution at Edgware was the third method, to make it available at sessions rather than sending it out with the call-up invitations or handing it individually to each donor. Do you recall any discussions about why that particular method of distribution was going to be adopted?
Yes, because it was in practice. Well, we couldn't do it. We couldn't send it to the donors because we had postcards, so we couldn't enclose anything with the postcard, and we didn't have the staffing to give it individually to donors. So at that time it was available, and some of the nurses or donor attendants said that we left it on top of the, I think we left it on top of the chairs of each. There was chairs in the waiting area, and the donor attendants said, well, some of them read it and some of them don't.
Now, we can look, I think, at how the practice we changed or was tightened up to some extent. But first, just taking it chronologically, if we could go to NHBT 0092842. If we go to the second page, this is now April 1984, so it's some months on from the leaflet first becoming available in September 83. This is a meeting of the Eastern Division consultants, and we can see that you were in attendance. And by this time, you are now the Regional Transfusion Director, having taken over in February 1984. Dr. Hewitt from North London is also there. If we go, please, to page 4. Third paragraph down is a heading AIDS. Dr. Rogers, who was chairing this, which centre was Dr. Rogers? Can you recall?
Tooting.
Dr. Rogers expressed the view that DHSS policy on homosexual donors had been too laid back. It was felt that the AIDS leaflet should be revised to include reference to plasmapheresis donors, and that more positive publicity to discourage donation should be channeled through dedicated journals. So 3 points being made there. Policy being too laid back. Do you have any recollection of what that's referring to, whether it's the terms of the leaflet or something else?
I think it refers to the leaflet and not as being proactive enough.
And then it says, the second point is the AIDS leaflet should be revised to include reference to plasmapheresis donors. Do you know why that was being suggested?
I can't remember. It must have been because plasmapheresis donors donate so often, so the risk of transmitting an infection is multiplied.
And then the third was more positive publicity to discourage donation through dedicated journals. So using publications to try and get the message across about discouraging high-risk groups from donating. Then in the middle of 1984, June, July 1984, as I understand it, you made a trip to the New York Blood Centre. What was the purpose of that trip, and what did you learn that was of relevance or use to the way in which the centre operated back in Edgware?
Well, we were concerned, as a team, because more and more publications were coming forward about transfusion-transmitted AIDS at that time. So, and I had a strong link with the New York Blood Center because my first tutor was working at the New York Blood Center, Professor Rubinstein. So, in conversation with him, he said, "Oh, we're dealing with high-risk groups in a confidential manner," and so I said, "Well, we should go and see this," because everybody was so frightened of asking donors about their sexual practices, etc. So I got money. I convinced my regional health authority to pay for a trip for Dr. Barbara and myself to go and see personally how the New York Blood Center was dealing with these donors in high-risk groups of transmitting HIV. And we went there, and we saw that the donors were quite happy, especially because the demographics of New York is very similar to the London demographics. So, we went to the donor sessions, and we saw that the donors were quite happy to answer this. They had a self-exclusion questionnaire, and to go into a cubicle and answer in confidence whether they were in a high-risk group and whether they wanted to exclude themselves or continue donation. So we learned from them, and we, on the plane back, we wrote our self-exclusion questionnaire and tested it at the Western Donor Center, at the plasmapheresis clinic, the main plasmapheresis clinic at the time, and then in the other plasmapheresis centers.
And my understanding from reading various articles, I think, that were subsequently published by you or your colleagues at North London, is it was in around July 1984, so not long after you came back, that you did the trial of the questionnaire in one of the clinics.
Yes.
And then, I'm not sure of the precise date, it may be that the reports will tell us, it was then rolled out at a later stage across the other donor session locations.
Yes.
And then perhaps just the last document for today, if we go to NHBT 00177776. This is a memo from you, 16th of October 1984, to all medical officers, re-AIDS leaflet. Because the revised AIDS leaflet is not yet available from the DHSS, we have had our present leaflet overprinted. In the section Who is at risk from AIDS, number 1 has been altered to practising homosexuals. These leaflets should now be available at all sessions. The original leaflet is being withdrawn. Just before we look at the next paragraph, is it right to understand that you essentially got fed up of waiting for the revised leaflet to be produced by the department, so you took this crude way of,
yes,
of just printing over the existing one, changing the reference to having had many sexual partners, whatever it was, to practising homosexuals, which was going to be the text of the new leaflet when it was eventually produced?
Yes.
And then the second paragraph tells us a further leaflet, Some Reasons Why You Should Not Give Blood, is also being distributed for donors to read before seeing the receptionist. We hope this will, 1, save some donors an unnecessary wait, and 2, focus attention on the AIDS leaflet. So this is an additional document that was being produced at the North London Centre, is that right?
Yes.
Do you recall what the text of it was at all?
It had the list of reasons why you should not give blood, but emphasizing the AIDS risk.
So, given the time, I've still got a number of questions in relation to this topic. I'm not going to complete it within the next few minutes, so perhaps we could break until the morning.
Well, I think that's very sensible. Professor, we'll take a break now and until 10 o'clock in the morning. Thank you very much so far. And we look forward to seeing you then at 10. 10 o'clock tomorrow.